Okay, for our final presentation today, Dr. Terry Watnick is joining us from Baltimore, and she's going to be talking today about aneurysms. Dr. Watnick is an associate professor of medicine in the Division of Nephrology. She has established an inherited renal disease clinic at the University of Maryland. She has also been an investigator in several multi-center clinical trials recruiting patients with ADPKD, including TEMPO. She moved to the University of Maryland School of Medicine in 2012, where she leads the Baltimore Polycystic Kidney Disease Research and Clinical Core Center. She currently serves as the SAC Chair for the PKD Foundation's Board of Trustees. Dr. Watnick received her medical degree from the Yale School of Medicine and completed her internal medicine training at Yale New Haven Hospital. She then moved to the Johns Hopkins Hospital, where she received clinical training in nephrology. She also completed a research fellowship that was focused on the genetics of autosomal dominant polycystic kidney disease. Dr. Watnick subsequently joined the faculty at the Johns Hopkins School of Medicine, where she rose through the ranks to associate professor. During this time, she continued to develop her clinical and research interests in inherited kidney diseases. Dr. Watnick, I'm going to turn this over to you so that you can run your slides. Okay, you should be getting control. We see a beautiful fall picture. There we go.
Do we want to go back to the beginning? Hold on. Okay, so how do I advance? Okay. All right. I just want to thank everyone at the Foundation for organizing this really wonderful day, and it really is a testament to the wonders of technology that we now have, where we can all be in different cities and learn together. So today I'm going to be speaking about aneurysms and autosomal dominant polycystic kidney disease. If I can, it's not advancing. Let's see. Yeah, I'm trying. No. Okay, we're having a little technical issue. Let's see. This one?
No, this one.
Okay. Okay, got it. Okay, so today I'm going to start out by talking about describing what is an aneurysm. Then I'm going to move on and speak a little bit about aneurysms and autosomal dominant polycystic kidney disease. We'll touch on screening, treatment, and then just because it's a topic that I'm really interested in from a scientific point of view, I'll just do a little tiny bit of the science. Okay, so what is an aneurysm? As you've heard in prior talks, I think you can look at it as a localized weakness in a blood vessel wall. Okay, and this results in ballooning and dilatation of the vessel. And seen here is what is a cerebral aneurysm or an intracranial aneurysm in the brain, which is one of the main types. And what you can see here is this small balloon that has occurred in this vessel in the brain. The second major type of aneurysm is an aortic aneurysm. And the aorta, shown here, is the main blood vessel in the body that leads to the heart, leads from the heart, and branches out to supply all of the blood in the body. And sometimes you can see an aneurysm or a dilatation in the aorta. So that would be an aortic aneurysm shown here. Here would be a thoracic aortic aneurysm, which is what occurs in the aorta, the part of the aorta in the chest, or an abdominal aortic aneurysm, which is occurs in the aorta that when it's passing through the abdomen. Okay, so most intracranial aneurysms, and that's what I'm going to focus most of my talk on, occur in the blood vessels of the brain in a part called the circle of Willis, and that's shown right here and magnified right here. So these vessels over here would be considered to be the anterior circulation, and back here is the posterior circulation. And for reasons that we don't understand, these vessels are the ones that are primarily predisposed to developing aneurysms. Okay, so as I'm sure you all know, aneurysms, intracranial aneurysms, are more common in autosomal dominant polycystic kidney disease. Okay, and so what I'm showing you here, and this is a little bit of a busy slide, but it's 4 different studies that used MR angiography to just screen all comers with autosomal dominant polycystic kidney disease. There are some older studies, but extending all the way up to 2011, and this is comprising really a large number of individuals in aggregate. And so what I want you to focus on here is the overall detection rate. So all comers, if I took 100 people walk through the door with PKD and I screened every single one of them by MRA, you can see here that the range of aneurysms extends anywhere from between about 9 to 12% of individuals will have an aneurysm. And that is in comparison to the incidence of intracranial aneurysms in the general population, which is about 2 to 3%. So that's about 4 to 5 times more common in ADPKD than in the general population. Okay, but the take-home point is here in this next line, where they have looked at the rate of aneurysms or hemorrhage only in those with a family history. So if you separate it out and look at those with ADPKD and a family history of aneurysms, you can see that the percentage all of a sudden increases quite dramatically to anywhere between 20 and 25% of individuals. So what that is telling us is that a key risk factor comes from your family history. If you separate it out and look at those without a family history, it's about 6%. So a really important part of the risk for aneurysms and PKD comes from that family history. Okay, and if you look then at where these aneurysms are occurring, it's primarily in the anterior circulation, and most of them, when you do this kind of MRA screening, turn out to be on the small side, which has important implications that we'll talk about as we move on. So this is just to show you an example of how family history can be quite dramatic for this, and illustrates that intracranial aneurysms are more common primarily in certain families. And this is a family that I have seen in my clinic, and this individual here was my patient, and she had had 2 aneurysm clippings by the time she was 32 years of age. And when I took her family history, I was quite impressed, because she had had 2 brothers that had actually suffered from sudden death and had been found at autopsy to have ruptured intracranial aneurysms. And then she had a 14-year-old niece who also had an aneurysm. So this kind of gives you the idea that this tends to cluster in families, although not 100%, but it's a strong risk factor. So why do we care about aneurysms? So we wouldn't care if they just stayed there and didn't bother anyone, but we are very concerned because these can rupture, okay? And a ruptured intracranial aneurysm can be a significant cause of morbidity and mortality, okay? The reason is because when this blood vessel ruptures in the brain, as you might imagine, you get bleeding into the brain, and that's called a subarachnoid hemorrhage. It's blood in the brain. And when this happens, suddenly it's really associated with significant morbidity and mortality, about 10% mortality before reaching the hospital, 45% mortality at 30 days, and only a third really have a good outcome after treatment, and there can be significant neurologic deficits. So those statistics are all from the general population, but they probably apply to PKD equally. So we like to know about this beforehand because we don't want to have one of these rupture unexpectedly. So that means that we should be screening for these, okay, because if we do find them ahead of time, I think the field has advanced really significantly such that we can treat these sometimes non-invasively. So there are several ways that one could pre-symptomatically screen for aneurysms. One would be CT angiography, where you get contrast in your vein, and it's basically a CT scan that gives very high resolution. The disadvantage of this is that it requires IV contrast, which can be toxic to the kidney. So that is not the preferred method of screening in my view. It is pretty good at detecting aneurysms, but it may miss some of the smaller ones. Okay, MR angiography, or magnetic resonance angiography, which is not the same as an MRI, I want to point out, because a lot of times people come and they say, oh, I've been screened, and I look and what they've had is an MRI, which looks at the brain parenchyma but doesn't really look at the vessels, you need to have an MRA. And this also, I would say, is equally as sensitive as CT angiography. It will also miss some of the very small aneurysms, but is very good for detecting aneurysms in greater than 3 to 5 millimeters. 3D time of flight with the better magnet, which is a 3 Tesla, has greater than 95% sensitivity. I think it's the preferred method of screening because it does not require any type of contrast. The one disadvantage is that it can be contraindicated if you have like certain metal devices that are not compatible with having a magnet. So pacemakers would be one. Used to be that the clips that were used for aneurysms were not compatible with MRI, but now they all are. And the other disadvantage is that if you have claustrophobia and you can't sit in this small machine, that can be a disadvantage, although we can use medicines for that, or we can try. So I think most experts would agree that MR angiography is the screening method of choice now in 2015 for pre-symptomatic aneurysms. So the gold standard is digital subtraction angiography. That, I want to stress, is not a screening method, but it is the gold standard and the most sensitive way for detecting aneurysms. So if one is detected on an MRA, many times it will be used to better define the aneurysm anatomy prior to intervening. It does use iodinated contrast, which can be toxic to kidneys, and so it isn't really recommended as a screening modality. And there are some older studies that suggest that this type of angiography, which is similar to an angiogram that you would do for the heart, except you're looking at the brain vessels, that there is a higher incidence of complications in PKD. So yes, it has an important place, but not as a screening method. So the next question I want to address, which is an important one, is who should be screened? And I think we had an international consensus conference back in January of last year where this issue was discussed, and I think the consensus was that most experts do not recommend screening everyone. Okay, mostly because the risk is not that high if you don't have a family history. So who should be screened? If you have a family history of intracranial aneurysm or subarachnoid hemorrhage or sudden death where there's a concern that someone may have had an aneurysm, if you yourself have had a previous aneurysm rupture, if you're in a high-risk profession, and I probably should take out airline pilot in terms of what happened last week, but certainly if you are in a profession where if you did have an aneurysm rupture, you would put the lives of a lot of people at risk, then those people should be screened. And if you're just really anxious about your risk, I think that's an indication to do it. So some experts, not all, would recommend screening those individuals who have de novo PKD. So they're the first person in their family to have PKD, but they don't have a family history, or there is an incomplete family history. So for example, if one is adopted and just doesn't know their family history, or in some centers, and I think Mayo Clinic is one of them, those undergoing major elective surgery, okay, such as transplantation, liver resection, or cardiac surgery, where there may be a lot of swings in blood pressure under anesthesia and you would be worried about rupturing an aneurysm. So under those circumstances. Another approach, which is one that some people have written about in the literature, so I mentioned, is to screen everyone at the time that they're diagnosed and then repeat at 2 to 10-year intervals depending on your risk factors. So if you have no family history, then probably there's no need to repeat it, but if you do have a family history, then you might repeat it more frequently. Okay, so I want to spend a little time looking at the characteristics of aneurysms in the ADPKD family, in the ADPKD population, and I've picked this study which was on that table that I showed initially, mostly because it is the largest study. It was conducted in China, and they screened 355 individuals with PKD by MR angiography. And they found 44 aneurysms in those 355 individuals, which is about 12.4% of the population. And what I'll point out from their findings is that the prevalence increased with age, that most of the aneurysms were small, less than 10 millimeters, and that's shown here in this table. If you look down this is all of the aneurysms. You can see that there was really only one that was greater than 10 millimeters in size, and most, nearly 100%, are going to be in the anterior circulation. And as I'll talk about later, those are the ones that are probably at the lowest risk for rupturing. There was no association with gender, so it's not that males or females develop this more frequently. There was no direct association with hypertension, no association with renal function, so it's not that these come on once you have kidney dysfunction, and there was also no association with liver cysts. Okay, so next question is, so what if you are screened and an aneurysm is found? I just want to stress that I think management decisions should involve a multidisciplinary team. As a nephrologist, I'm not a neurosurgeon or an interventional neuroradiologist, so those individuals with that type of expertise should be included on the team that's going to decide what's going to happen. Okay, so the treatment options include observation with just serial imaging studies, surgical clipping, endovascular coiling, and everyone should have lifestyle modification. Okay, so I'll just go through some of that. So one thing I want to say is that most intracranial aneurysms actually are asymptomatic with that until they rupture. And some of the data or some of our recommendations for treatment actually come from the general population. It's not that these management decisions have been studied particularly in PKD because it's relatively uncommon and there aren't large enough studies. So first, cigarette smoking. We have to, cigarette smoking is a risk factor for aneurysm rupture in the general population, and that's just one study, was a retrospective study of 45 males and 70 females who had had a subarachnoid hemorrhage due to an aneurysm rupture, and they had 3 to 4 times the risk of having been cigarette smokers, so we don't tell people to stop smoking, which we should anyway. Heavy alcohol consumption has been associated with rupture of intracranial aneurysms, out-of-control hypertension, and that's in the general population. But the major risk factor for rupture, and that's what I want to stress, is the size. There was one very large international study that looked at this, and that's that Isuya study. And the risk of rupture was lower in small aneurysms that were less than 7 millimeters in size. They also found that intracranial aneurysms in the anterior circulation were also less likely to rupture, which is where most of the aneurysms in PKD are found. So the 5-year rates of rupture for aneurysms in the 7 to 12 millimeter size were about 2.6% for the smaller aneurysms, 13 to 24% for the middle range, and then much, much higher, 40% for those aneurysms greater than 25 millimeters in size. Also, aneurysms in the posterior circulation are more likely to rupture. Okay, so what about PKD? So there haven't been very many studies, but this is one from France, Chavot et al. They looked at 71 cases of ruptured intracranial aneurysms in autosomal dominant polycystic kidney disease. They found that the mean age of rupture was about 40 years. That's a typo. And what was interesting, that is younger than in the general population, but about 10% were under 21 years of age. So that speaks to some primary abnormality in blood vessels in PKD, because in the general population that would really be exceedingly rare. About 50% of their patients had a normal serum creatinine, 30% were normotensive. And although there was increased risk of rupture at the bigger aneurysm size, bigger than 6 millimeters, which was what was found in the general population, rupture at very small sizes was also reported, again speaking to that there's perhaps some blood vessel abnormality. And then 30% of their patients had multiple aneurysms. So what should we do if we do find an aneurysm? Should we intervene right away? What happens if you're observing these things? So this is a study, I think, from the Mayo Clinic, and they followed 38 individuals who had aneurysms detected at screening. And they found that in general, the prognosis was quite good and that they tended to remain stable. They found only 1 new intracranial aneurysm and 2 that increased in size. And so their findings can be summarized as, in general, intracranial aneurysms, especially the smaller ones and those less than 7 millimeters, tend to remain stable and can be followed. But of course, that's something that you need to discuss with the experts, neuroradiology, neurosurgery. Okay, so what if it's determined that an aneurysm should be treated? I just want to go through the different modalities. So the first would be surgical clipping, and that's kind of shown here schematically. The goal is to place a metallic clip along the neck of the aneurysm like that. This type of surgical intervention obviously involves a craniotomy, which means that you have to get into the brain surgically. This clip, once it's placed, and that's shown here in an actual surgical field, remains in place for life. And the hope is that the aneurysm then scars down and goes away and then can't rupture anymore. So obviously this is invasive. The mortality is about 1.7% with this type of surgery, so it's not insignificant. And there are unfavorable outcomes in about 6 to 7%. So it's a big surgery. It also involves some risk. So what about endovascular coiling? So that's newer. It's less invasive. And what you do here is that involves an angiographic approach. So just like you would have coronary angiography, it's for the brain. And what happens is platinum coils are deposited into the aneurysm. Okay, so this is from a patient that I followed, and you can see here this aneurysm, and then this was coiled, and that's just showed schematically here. They go up angiographically. They put these like platinum coils in here, and then this kind of causes the aneurysm to clot off and go away, and that's what's shown here. So the complications can include thrombosis or clotting where you don't want it to happen, or rupture during the procedure. I think that it is generally accepted now that in centers where there's tons of experience with these procedures, these are associated with lower morbidity and mortality in comparison with the surgical approach. And so I think that this type of methodology is playing an increasing role in the treatment of unruptured aneurysms. And from what I could gather, I'm not a neuroradiologist, this is a very, very rapidly evolving field. New methods are constantly being developed, and I think they're probably going to get better and safer. So even more reason why we want to know if somebody has an aneurysm, because this type of intervention, I think, offers, in centers where there's a lot of experience, less morbidity and mortality. So intervention, as I said, though, overall does carry risk. The risk factors for a poor outcome with intervention includes an older age, larger aneurysm size, location in the posterior circulation is more risky, and just to say that poorer outcomes seem to be more consistently observed in surgically rather than endovascularly treated patients in centers where there's a lot of experience with these methods. Okay, so in summary, just to summarize, the therapeutic approach for aneurysms is determined by the size and location and anatomy of the aneurysm, which is determined by, in conjunction with the neuroradiologist and the neurosurgeon, the general health of the individual. If someone has a lot of other comorbidities or medical problems, all of these procedures are going to be more risky. So you always have to weigh the risk of rupture versus the risk of intervention and versus the risk of just observing over time. This is best decided by an expert team and treatment in a center with high procedure volumes where they have a lot of experience with all of these methods. I think lifestyle modifications have to be implemented for everybody, and that should include smoking cessation, treatment of hypertension, and treating high cholesterol with a statin. Okay, so what if you get a screening MRA and it's negative? Okay, so can you just leave it at that, or should you be rescreened? So this is a study from the University of Colorado where Bob Schreier followed 76 individuals with autosomal dominant polycystic kidney disease and an initial negative screening. And then he went back in 10 years to see what had happened. And over that period, there were only 2 new aneurysms detected. One small aneurysm, when they looked back, they realized it had been there the whole time and hadn't changed. It was small, 2 millimeters. There was only 1 individual that they found that had several new intracranial aneurysms, and that person had a positive family history of aneurysms and PKD and also had a significant smoking history. So the recommendation was to rescreen if you were at high risk. only, so meaning if you had a positive family history. And they recommended rescreening at 5 to 10-year intervals. I think you can probably come down to 2 years depending on the family history. So why don't we like ruptured intracranial aneurysms? As I mentioned, it's a medical emergency. It means you have bleeding in the brain, which can cause, a lot of neurologic impairment if you even survive. So how would one think that one would have a ruptured aneurysm? The classic symptoms of that are a sudden or intense headache, and that happens in nearly 100% of people who have a ruptured aneurysm. It's described as you feel an explosion inside your head. The medical term for it is a thunderclap headache. It's often described as the worst headache of one's life. So if someone calls and says they have that, you should probably tell them to go to the emergency room. About 20 to 50% of individuals who have a ruptured aneurysm might have an acute or transient headache in the days or weeks preceding it, and that's a sentinel headache, and it's probably due to small leaking, and so it could be a warning. Other symptoms of a subarachnoid hemorrhage or ruptured aneurysm include nausea, vomiting, photophobia, which means light bothers your eyes, any type of a focal neurologic deficit, seizures, transient loss of consciousness, or sudden death. The diagnosis is made very much using the same methodologies as we use for screening. However, you're not really probably worried about giving contrast in that setting. So a non-contrast CT, the sensitivity is 100% within the first 6 to 12 hours because it will show blood in the subarachnoid space. A lumbar puncture or taking a little bit of cerebrospinal fluid from the back will also show blood. Once a diagnosis of a subarachnoid hemorrhage is made, you have to do digital subtraction angiography, or putting contrast and having a very good look at the intracranial vessels, and that's just showing what a digital subtraction angiography is. This is the most sensitive method for detecting aneurysms, as I said, and so this is where you would sort of figure out what happened and what intervention is appropriate. So the treatment of a ruptured aneurysm, this is a medical emergency. There are improved outcomes in high-volume centers where there are appropriately trained people to deal with this, neurovascular surgeons, endovascular specialists, and a neuro-ICU. Almost always these people are admitted to a neuro-ICU for specialized care. As we said, neurologic sequelae can be substantial. The timing and choice of definitive therapy, again, is going to be made by a team of experts. Just because you have a headache, it doesn't mean that you've had a ruptured intracranial aneurysm. There are many other causes of severe headaches. I've just listed those here for completeness. Strokes, other type of strokes can also cause headaches. Hypertensive emergency or having super high blood pressure. Dissection of one of the other blood vessels going to the brain. Meningitis, any type of infection, in the brain. A tumor or migraine headaches can also cause severe headaches. So I think some of the other speakers alluded to this, that autosomal dominant polycystic kidney disease is associated with a, quote, vascular phenotype. So even though intracranial aneurysms and PKD is probably the best recognized association and the one that would be the most studied, aneurysms have been reported in numerous other vessels, okay, in PKD, and you can find case reports of a lot of this stuff. Ascending aortic aneurysm would be one in particular that I think has been noticed, and that's the part of the aorta that comes out of the heart. Popliteal artery, which is in the back of the knee, splenic artery, and coronary arteries you heard of before. You heard from Dr. Winkelhofer. And just to sort of drive home, I mean, you don't usually have dissecting aortic aneurysms in the general population at young ages, and this is a patient I had seen who was 23 years old, and he had a dissecting aortic aneurysm that basically went all the way down. It was repaired. And this is another cardiac MRI from a patient who was only 18, and she had PKD. It was relatively early, but she had a dilated aortic root, and this had to be repaired. So it gives you the feeling that there is some kind of an issue with blood vessels. I don't think the basic biology of it is something that's very well understood. One question that I think comes up is why do aneurysms run in certain families? I will say that it can be associated with either PKD1 or PKD2, either one, but because it runs in families, it does give you the idea that there has to be something about the germline mutation that might predispose to this. This is a study that I did as a fellow where we studied 35 individuals who had either aneurysms or very early onset disease, and we found that 3 of these individuals actually had the same identical mutation, which is quite rare because most mutations in PKD are unique. Okay, and so that you would find in this small population 3 families that were completely unrelated that had the same mutation suggests that there's something about this that might predispose to aneurysms, although I say it's not well understood at all. Subsequently, the group at Mayo Clinic also characterized mutations in 58 families with a vascular phenotype. They found 51 PKD1 mutations, 7 with PKD2, and they also found 3 families who had the exact same mutation that we had identified. They reported that mutations that were more in the beginning of the PKD1 gene were associated with aneurysms, but subsequent studies have not confirmed that. So I think it's something from a biological point of view that I would like to understand, and I will say, and I don't mean to disturb anyone, but we have laboratories here, and we do have mice that have PKD mutations, and what you find is when you completely knock out the PKD genes in mice, you do have a vascular phenotype, and that's shown here in both PKD1 knockout mice or PKD2. They have a hemorrhage under the skin, which suggests that the blood vessels are fragile or leaky in some way, and they also have edema. Okay, and so just to give you a little bit of basic biology, all of the PKD genes and proteins are actually expressed in blood vessels, quite highly in fact, which suggests that they have some function there. And this is an old study where someone knocked in a reporter into the PKD1 gene, which means that everywhere where these genes are expressed, you're going to see blue color. Okay, so this is taken from those mice, and this is the ascending aorta where I told you that you sometimes see aneurysms, and you can see that very dark blue color means that the PKD1 genes and proteins are really highly expressed in that location. Here is the aorta, the abdominal aorta with the iliac branches, and again you can see it's quite blue and there's high expression there. And then here is that circle of Willis that I told you about in the beginning, and you can see that it's quite blue. So there's high expression of these genes there and also in the cushions of the heart. So this suggests that these genes and proteins are found there, that they have some function, and I would say we don't completely understand what that is yet, and it may have different functions during development as once you're developed and in an adult. And again, this is from some other mouse studies suggesting that when you completely knock out these genes, the capillaries are leaky, and so that's just from a skin sample. This is the higher power of that, and you can see all of this red is red blood cells that have leaked outside of this little blood vessel. So PKD1 mutations, at least in mice, when you completely knock it out, cause vascular fragility, and so this has given us the idea that polycystins, or the PKD genes and proteins, are required to keep your blood vessels in good order, working order. Okay, and when you don't have this, they may leak, and this may in fact also be due, somebody had said this, due to connective tissue disease, because in many connective tissue diseases actually aneurysms are also a very prominent finding. So there seems to be some connection there. I think from a very basic biological point of view we don't understand it very well, but it would be something we would want to understand, because if we had a better handle on it, maybe there would be some way to intervene. So I'm going to end here and just have a couple of conclusion slides to summarize what I said. So first, the risk of intracranial aneurysm is increased in autosomal dominant polycystic kidney disease, and especially in those with a positive family history. Intracranial aneurysm rupture, if it does, results in significant morbidity and mortality. MRA screening is recommended in high-risk groups, primarily those with a family history of intracranial aneurysm or subarachnoid hemorrhage, previous aneurysm rupture, any high-risk profession or individuals who are anxious about their risk and would like confirmation that they don't have it. If you do have an aneurysm, it should be, the treatment method should be decided by a multidisciplinary team of experts, whether to observe, as you would in a very small aneurysm, or clip or coil. This involves weighing a lot of factors such as the size of the aneurysm. So as I said, a smaller aneurysm, the likelihood of rupture is quite small, so those may not be amenable to any type of therapeutic intervention, or the risk of the intervention is going to be higher than observing it. So you're going to follow those. It depends on the location and the anatomy of the aneurysm. So for example, some are just not going to be amenable to coiling. You should eliminate tobacco, which you should do anyway. Treat hypertension probably anyway, and hyperlipidemia with a statin. And there's some evidence, at least in the general population, that treatment with a statin, whether or not may have independent beneficial effects, might damp down on any inflammatory component. So aneurysms in other large vessels, and we heard about this earlier today, have been observed in autosomal dominant polycystic kidney disease. Aneurysms are associated with both PKD1 and PKD2 mutations. Polycystins are expressed in the cells that line blood vessels, and these proteins probably play an important role in development of the vascular system and maintenance of the vascular system. And so I'm going to stop there, and just any questions or thoughts.
Thank you, Dr. Watnick. We are a little bit over time, but we have a few questions that I don't think were addressed in your talk, so I did want to ask a couple of those. The first one, do extreme sports raise the risk of aneurysm or ruptures?
That's a good question. I think most of the data in that regard would probably come from the general population, and I'm not aware of that. But I would imagine, I suppose, if you're doing that and your blood pressure is not controlled, I suppose you could theoretically suppose that there might be some risk, but overall I think the benefits of exercise outweigh the risks.
Okay, and we have several questions from people that want to understand a little bit more about aneurysms post-transplant. So how often should a post-transplant kidney patient have scans for aneurysms, and also does your risk of aneurysms or ruptures go down after transplant if your native kidneys have been removed, and also if you have normal to low blood pressure after transplant?
Okay, so as far as I know, there have been no formal studies of any of those questions, but I don't think that the approach to screening changes after transplant. There are going to be those centers that are going to screen people before they have a kidney transplant with the idea that you are putting a valuable organ into somebody and you want to make sure that they're going to do well. But I think that aside, there's no increased risk of aneurysm or rupture after transplant, and I think the approach to screening is probably the same. Did I get all the questions? And if the blood pressure is low, I don't think that would impact at all one way or the other.
Okay, yes, I think you addressed all the questions that I asked, but there's a whole lot more that I know we're not going to get to, and I really wish we could. So the next one here is, how damaging is contrast imaging to the kidneys?
Yeah, so of course, it's going to depend on the degree of kidney dysfunction that you have. So probably if your GFR is relatively well preserved and you get contrast, we don't like it, but you probably will be fine. Just have to make sure that you're very well hydrated when you get it. As with anything, you always are weighing the risks and the benefits, right? So if you have an aneurysm and it's ruptured, I mean, there's no choice essentially. That's a life-threatening condition, and you have to get the contrast and hope that all of the preventive measures, hydration, before are going to prevent any bad findings, any bad sequelae from the contrast. But yes, there's always a risk. I think the risk is much lower if you have preserved kidney function.
Okay, thank you. And one more question. What percentage of patients have clip versus coil surgery, and why?
Okay, so I don't know the percentage, and you probably, that's going to be a moving target as coiling gets much, much better. And there are just some aneurysms just based on the anatomy that are not suitable for coiling, and others will be. I think that will be the preferred method if the aneurysm is suitable because it's a lot less invasive. But okay, again, it's going to depend on the size, the location, the anatomy, how wide is the opening to the aneurysm. There are a whole bunch of factors. And that's why it's so important to have experts involved who are really, really familiar with these methods and what's appropriate.
Okay, and I'm going to ask one more. There's a lot of questions about no family history of aneurysms, should we be screened, or if you are unsure of the cause of death of family members that you know had ADPKD that have passed away. So could you just talk a little bit in general again about who should be screened and family history versus no family history?
Okay, so if you know your family history and you have no one in your family has ever had an aneurysm, the recommendation of most experts is that screening is not necessary. Okay, if you are unsure of your family history, so you just can't get at it, or you're the first person in your family to have PKD, I think there's a difference of opinion. There are different opinions. Some people would say it is not necessary. Others would say you do it once, and then there's no real need to rescreen very frequently because the incidence of new aneurysms is just quite small. If you have a family history, or if someone in your family had sudden death and you're not sure, I think it's best to err on the side of being screened.
Okay, thank you so much. It truly pains me to say this, but that is all the time we have for questions today. I want to thank our presenters, Dr. Perrone, Dr. Winkelhofer, Dr. Hogan, and Dr. Watnick for sharing this valuable information today. We really appreciate all the time that you have taken to join us today and to prepare for this conference. So again, just a huge thank you to you for being here today. And I do want to say really quickly, I'm going to turn the microphone over to Dr. David Barron again for some closing remarks, but I do want to address that we got a lot of questions today that we were unable to answer, and I did try to combine some of them and generalize a little bit to get as many as we possibly could. But I do want you to know that we will do our best to take a look at the questions afterwards, post some answers if we possibly can, have another program of some kind that addresses some of the questions that we had. Some of the questions were not necessarily related to the presentations, and I did skip a lot of those to get to some of the questions that were related to the presentation. So we will do our very best to get answers. I know all of these questions are very important, and we do want to answer them if we can. So we'll do our best to get answers.